You're listening to Medscape's In Discussion series on bipolar disorder, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Trisha Suppes. Dr. Suppes is a professor of psychiatry and behavioral sciences and the director of Exploratory Therapeutics Laboratory at Stanford University School of Medicine. She also serves at the Palo Alto VA as director of the Cooperative Studies Program Network of dedicated enrollment sites and a staff physician. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Trisha Suppes, and welcome to the Medscape in Discussion Bipolar podcast series. Today we'll be focusing on cognition and bipolar in part, as well as any broader concepts about bipolar that takes me to. Let me introduce my guest, who is both a long-term friend and collaborator, Professor Allan Young. Professor Young is the chair of mood disorders and is director of the Center for Affective Disorders in the Department of Psychological Medicine in the Institute of Psychiatry, Psychology and Neurosciences at King's College London, where he is also head of academic psychiatry. Welcome to In Discussion podcast.
Thank you for inviting me.
Before we sort of get into some of the finer details of cognition and bipolar, let's go back and look at the historical background. Then we can move more into discussing what we mean by cognition and where some of the current thinking is on what cognition is in bipolar disorder, what it means, what it matters to people. So do you want to just start off by filling in a little historical background?
So I might start with my own involvement, which really started when I was a young academic psychiatrist in Newcastle about 30 years ago. Enduring bipolar depression is, of course, a big issue. But even when people came out of bipolar depression, they were still complaining of not being fully mentally as they were before their illness. Of course, they wouldn't come up on a dementia screen, something like the MoCA or the mini mental state, and their IQ scores were still quite good. But they were complaining of not having the same abilities that they had before with attention, concentration, planning, and so on. So that's really where we got into the whole field of cognition. And the story goes both back and forward, actually. There's been a lot of work on it, but there was some work preceding this, mostly in schizophrenia. I started off in schizophrenia research in the 80s, and I always think that people who are researching in bipolar, because there's such an overlap with schizophrenia, it's always good to look and see what the people are doing in the schizophrenia research field and see how it applies to bipolar and the similarities and differences.
Well, I think that's very interesting. And have you been interested in cognition ongoing since this early experiences in terms of patient experience even?
We started off from then doing two parallel strands of work. So we started doing studies in depression, major depression. And major depression is somewhat easier because you can get drug-free patients. And we showed there was a significant cognitive impairment in depression, which had different components. And with bipolar, we decided to look at people who were fully well, a bit like my original clinic, but to look at the various domains of cognition, things like attention, concentration, working memory, executive function, which many of us use every day in our jobs, but it's all about planning, strategies, set shifting. Many of our patients had jobs that required this. So we did a big study that we published in 2005, and we looked at about 60 patients with bipolar disorder versus 60 controls. And we were struck with the size of the cognitive impairments. So the first thing was really to establish that this was a real thing, and then to try and understand the causes of it, the course of it, and then eventually get around to potential treatments.
From some of the reading I've done and speaking with you and others in this focused on this area, it seems like there is a range of prediction regarding how many people will have cognitive issues. And again, you've mentioned important domains such as the ability to focus, stay focused, so attention and concentration, working memory, retrieve, and executive function, which is critical for any kind of job, really, particularly one, of a higher level. Set shifting is a good example of that, and planning. So what % do you feel folks with bipolar when they're euthymic, so not in an acute episode, still have cognitive issues or residual cognitive issues? think everyone would agree that during an episode, cognitive problems go along with having an episode. But post-episode, because I've read anywhere from 40 to 60% have ongoing cognitive issues that you can measure. What's your sense, both clinically and in terms of the science you've done?
It's not everyone with bipolar disorder, but it's a significant percentage, and it depends on your sample. If you look at post-first episode mania, say, the percentage is going to be less than people who've had 10 episodes, because we think there's a progressive effect on cognition. And the other thing with bipolar disorder is we may be underestimating the cognitive deficits because there's what I like to call a hidden cognitive impairment. And that's very simply explained. So people with bipolar disorder start, on average, about 2/3 of a standard deviation higher than the average. So in the Dunedin study, the kids who went on to have mania, bipolar disorder, their average IQs were 110. So I think people with bipolar disorder can lose some of their cognitive abilities, but still score very much in the average or even above average range. So we may be underestimating it. And that's why patient reports are extremely important.
That highlights the possibility of longitudinal studies, of catching people before their first episode in longitudinal studies, which I know that now with the bipolar initiatives going on, they may potentially focus on that, because that would really allow you to capture people at high risk for bipolar who aren't actually yet having major episodes and see what happens. Because I think that compensation model is a reasonable one that needs to be tested.
Yeah, I mean, I think one of the great data sources is the Dunedin study from New Zealand, where they did simple tests on kids in the first decade of life and then followed them up to their 20s when they would have developed schizophrenia or bipolar. And the kids who went on to develop schizophrenia were on average impaired on the simple tests well before any manifestation of illness. The kids who developed bipolar on average were doing better, but it went down with each episode of mania. Having said that, there is a subgroup of people with bipolar disorder who have a particular pattern like the schizophrenia group pattern, which is more neurodevelopmental. And some of the old work from Canada, Paul Groff's pedigrees, and some of the newer work, for example, Bernard Baun and Thomas Schutz's work on lithium responders, suggests that the people who have the more neurodevelopmental loading to their cognitive impairment in bipolar are also the people who don't respond to lithium. So I think that's an important subdivision, really.
What do you think about this recent work using functional imaging to suggest the cognitive control network and default mode network might be treatment targets for residual symptoms in cognition?
I think that's very exciting and very interesting. I think that's exactly the type of methodology we need to develop if we're going to really get into experimental and translational medicine for development of new cognitive treatments. At the moment, I don't think we're quite there yet, but I think we could see that we would have even potentially target engagement being shown with some of these neuroimaging profiles. But to get back to treatment, it's still very preliminary with any treatment whatsoever. And of course, treatment can be pharmacological. It could be psychological treatment like cognitive remediation. It could be neurostimulation. It could be a combination of all three. And we have interesting preliminary studies in many areas, but we don't have the big definitive trials that would allow us to say this should be offered to patients yet.
Right. I was just so intrigued when I read it. I was curious if that could be a treatment target. Though I know the studies I've read, there was the one, I believe you're a co-author in 22. It was a meta-analysis, which of course always carries issues of you're lumping lots of studies, which may have very different characteristics of patients. But the patient number was over 800, and they were looking at different stimulation approaches versus cognitive remediation, which is basically just training your brain to be more on it, whatever it is, to be more awake, or medications. So it was limited, the medications they looked at. And interestingly, in this sort of messy meta-analysis, cognitive remediation seemed to be a clearer winner, so to speak.
We've done some of the cognitive remediation studies. We've done a pilot study, which was published with about 60 people, and we have a follow-up study, which is aiming for 250. And we used a cognitive remediation package developed for schizophrenia by my colleague, Till Wykes. And I think it would be fair to say that my colleagues who'd used this in schizophrenia were really amazed at the size of the benefits that we showed in our pilot study for bipolar disorder. So everything got better. Now, one of the reasons that cognition is important is because psychosocial functioning, how we function in the world, in work and at home and our personal life, psychosocial function is really determined by cognition. If your cognition is impaired, then your psychosocial function is impaired, including your workplace performance. In our initial study, and we can talk about how cognitive mediation works, it was very interesting that cognition improved in all the domains, really, but also psychosocial functioning improved as well. Probably the two are very much related. One of the points about cognitive mediation is that, they're not all the same. It'd be a bit like saying all drug treatments are the same and throwing in lithium with Haldol or whatever. This cognitive mediation package is very much interactive. There's two possibilities for how it's working. It may be actually remediating the cognitive impairment directly, or it may be teaching people new skills to sort of work around it, so-called metacognitive skills. We've done a lot of things trying to parse that out. I think there's probably an element of both. I also have a theory that if you have better cognition, that provides top-down control for mood stabilization. I think one of the things that goes wrong in bipolar disorder is that the cognition and the mood instability are not totally divorced in the brain. I think the way our brains work is our cognitive control and our emotional valence are very much linked. And when you lose the cognitive control, that can also cause mood instability. So it's very exciting. But one key point, and I would go back to the rest of medicine for this. If you're in infectious diseases or you're in cancer or whatever, you don't think that you'll just try one treatment and see if it works. If there's something that works and something else that might work, you look at the combination. So I think the future really is not only establishing efficacy for individual treatments, but looking and seeing whether cognitive mediation works well with certain medications or with certain neurostimulation packages or whatever. I think there's great scope there.
Well, that fits sort of what we know about the psychoeducation when it's very well developed and orchestrated. So cognitive mediation would fit right in there. I think your theory is very interesting, which I haven't heard well articulated before, but it has a resonance to me anyway, that if your cognition is disordered, your capability of stabilizing with or without meds may in fact be also impacted.
That's absolutely right. I think we don't know the direction of causality. I mean, I think it's certainly clear that the people who are cognitively impaired also tend to have unstable mood and a poor course of illness. Which way that's going is debatable, and it may be multiple interactions, but I think certainly it's credible that top-down cognitive control is important. And if you can restore that, you may make the course of illness better.
Well, and a parallel issue, which I think is different, is the question of insight. I'm not sure I would lump insight in terms of the cognition issues we're talking about, because someone who has bipolar and has no insight can be cognitively intact, but there's zero insight. This is happily not the norm, but you do see it. So I would separate those issues. Does that make sense to you as well?
Yeah, absolutely. I think one of the biggest issues we face in the clinical care of bipolar is denial. Like yourself, I'm sure. I've sat clinic many times with people who don't want to accept the course of their illness. And, you say to them, well, if you had diabetes type 1, would you go on insulin injections to control it? Yes, I would. If you had diabetes type 1 and you'd been on insulin injections for 5 years and you'd had no problems, would you come off them? No, I wouldn't. So why don't you want to accept the best management advice for controlling your bipolar? So I actually think that's almost more in the psychotherapeutic domain with trying to overcome denial. Therapeutic alliance between the physician and the patient and the family are very important. But there's a good deal of work for people who are fully well, who've recovered from the illness, but simply don't want to accept that they've got bipolar disorder. And we see that very often. And like myself, Trish, you've seen hundreds of patients with this illness. And, my view is that if we can negotiate denial and get to acceptance of the illness, that really improves the outcomes.
The metaphor I use is actually seizures. I don't use diabetes because like seizures, if you have a seizure disorder, you can stop your seizure medicine, but there's a 95+% chance you will get a seizure again if you have an established seizure disorder. So I tend to use the seizure disorder because people are on meds, they feel fine, so they're saying, why should I continue? And one thing that's useful when you're talking with someone younger, say in their 20s, is you're also usually dealing with the family. So the family can provide important information, not just about their denial, but also different in function, and in particular cognition. So we might be sitting with somebody, we haven't formally tested them, and they look pretty intact. They look fine. But if you talk to the family of how they were 5 years ago, you realize there's significant deficits based on the longitudinal course.
I'd like to make one other point, if I may, and this is much more of a clinical observation than anything we've ever reported in an academic paper. There's a differential rate of improvement in the cognitive domains. So things like attention and memory get better more quickly. The one enduring trait deficit is executive function, which people really miss. I mean, it's a bit like oxygen. You need it all the time, but you only really miss it when you don't have it. But prolonged euthymia, if people stay well, I've seen numerous people who said, it's come back. I feel I'm on top of things like I used to be. I think the bipolar brain is more plastic and able to recover than many others. This is why I was very keen to do this cognitive mediation study, because I thought this approach works for schizophrenia. It's likely to work even better for bipolar. And that's what our preliminary evidence suggests.
That's so interesting. And, depression recovery has a similar stepwise fashion. So energy and ability to do things may come back sooner, and then mood lags behind. So I think it's an interesting model to not try to look at everything and improving all at once, but there's the possibility of a cumulative improvement, which speaks to the importance that it's very important to try to keep people stable. That the more time they spend stable, their brain is stabilized. I think that they can see, continued improvement. So what are you working on right now in this area? Since I think it is a bit of a focus for you and your group, among other focuses.
Well, we've done a couple of things. We did some studies looking at stress hormone antagonists. And about 25 years ago, I visited your department, met Allan and got the idea of using the stress hormone antagonist that he was using to try and treat cognitive impairment. Well, we started off by doing studies in healthy volunteers where we gave them stress hormones for a week to mimic the level found in severe mood states, and we showed reversible impairments. And then we treated people with bipolar disorder with the add-on of the stress hormone blocker, and that reversed the impairment somewhat that we had induced in the earlier study in healthy volunteers. And then we went on and did a much bigger study where we replicated this effect, and we showed it doesn't improve everything across the board, but spatial working memory, verbal learning and memory significantly improve. What made that difficult to progress was the fact that in the first study, it seemed to have benefits for mood, but in the second study, they weren't there. So our funding agencies haven't been very keen on treating cognition or funding studies to treat cognition per se up until now. But what we have done with that is we've gone to look at the signal on neuroimaging, a bit like MRI, of these benefits to try and have the methodology for future experimental studies. But we've also done the cognitive remediation. And as I say, the cognitive remediation is a very interesting field. There's a whole group of researchers who are multidisciplinary neuropsychologists, some psychiatrists and so on, who are very interested in this area. It's obviously not just bipolar and schizophrenia, but that's a big part of it, or that's a big part of it for us. And I think the future is probably thinking about combining these approaches, looking at the best drug evidence, combining with the best cognitive remediation package, and looking at the effect on long-term outcomes. So one thing we're doing right now is our first cohort of 60 people that we treated with cognitive remediation. They're now a few years out. So we're going back and looking and seeing if we've changed the trajectory for those individuals. And of course, we're recruiting to the big follow-up study.
So is cognitive remediation, like cognitive behavioral therapy, something you do, say, over 10 to 12 weeks, and then maybe you have a booster session every 3 or 6 months? Or is it kind of one and done? How are you using it?
Yeah, that's a good point. I mean, it is actually, at least in our study, something that you do for, say, 12 to 20 sessions. You have regular sessions with a therapist and you have exercises. I mean, we now do it remotely and so on. And of course, there's a software component to it, but we haven't been doing top-ups. I think potentially you should be doing that. It's a bit like another area that we're both interested in, psychedelics, whether you should be getting people back and treating responders for top-up sessions.
So one thing I'd like to circle back, most of the studies which were mashup meta-analyses, which I'm not sure how good the take-home messages are from that. So they have bipolar 1, 2, BD, and OS, which is an even grayer area. What's your thoughts on differences between folks with bipolar 1 versus bipolar 2? And just for our listeners, bipolar 1, of course, includes a history of mania. Bipolar 2 is notable for mostly depression, but a clear history of hypomania. Course of illness is somewhat similar. Suicidality is similar between the two folks who have either one of those diagnoses. Functionality is a little better in bipolar 2 from the large Swedish studies, for example, though. So do you see a difference in cognition or approach to dealing with improving cognition in bipolar 1 versus 2?
Well, I think cognition's important across the whole mood spectrum. And of course, we think about the mood spectrum at one end being psychotic bipolar and the other end being straightforward MDD. We actually did a review of bipolar 2 and fill in all the bits from the literature. And it's quite striking that the cognitive impairments are fairly large with all of these disorders and appear to be related to episodes. It's very fashionable to talk about transdiagnostic approaches, but I think looking at cognition transdiagnostically but across the mood spectrum is the way to go. Of course, some people in all of these groups, bipolar 1, bipolar 2, will not be affected at all, but others with bipolar 2 will have deficits as large as people with bipolar 1.
Or schizophrenia. So just to close, an area that folks are so interested in, of course, is psychedelics. And we actually have a whole session, hopefully, on that down the road. Psilocybin in particular is beginning to be studied in bipolar 2. Do you think those studies will be including cognitive measures? Because I think that would be a really interesting adjunct to looking at the impact of these drugs on, how the brain is doing.
Yeah, absolutely. I mean, our psychedelics group, myself and James Rucker and others, we did a healthy volunteer study of psilocybin, and we looked at cognition as a safety measure, really to see if, there's any deleterious effects on cognition. Of course, there weren't any. But there's an important point here between treating cognitive impairment and cognitive enhancement. So in healthy volunteers, you can get a signal of where you make cognition worse or whether you cognitively enhance, you improve healthy volunteer abilities, but you can't really get a signal about whether you're treating a illness-related impairment. So I think looking at that in an ongoing fashion in all of the studies, both for safety and for possible benefits, is going to be extremely important. The other thing to say, and this is something that we should all bear in mind, is there's lots of secondary issues that impair cognition. So not only things like head injury, but also alcohol, for example, drugs abuse, cerebrovascular disease. So that's a sort of secondary way. If you get better illness control, whether it be bipolar or depression and bipolar 2 or MDD improved by psychedelics, the secondary contributors to the cognitive impairment may be lessened and you may get a better outcome that way.
Yeah, that's a really good point. For example, about 25% of patients with bipolar disorder, maybe even a little higher, have post-traumatic stress disorder. And I'm sure that would be a covariant for how well cognitively people are doing. So that's a great point to end on. Today, we've been talking with Dr. Young on a wide-ranging set of issues around cognition and bipolar. And for me, the main take-home here is that, in fact, we need to pay attention to cognition in patients with bipolar disorder, whether it's bipolar 1 or 2. And we need to be thinking about how this can be improved over time, and that the more someone is kept stabilized, then the greater likelihood is they'll see improvement across more areas than just mood stabilization. Thanks for tuning in. This podcast will be available on the usual platforms, and you may also want to download the Medscape app to listen. Please subscribe to this podcast series on bipolar disorder. This is Trisha Suppes for the Medscape in Discussion Bipolar Disorder podcast. Thank you very much for listening in.
Thanks for listening to Medscape's In Discussion Bipolar Disorder podcast series with our host, Dr. Trisha Suppes. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on bipolar disorder.